So moving forward with our first speaker, please join me in inviting Dr. Kanthi Bansal ma'am. She'll be speaking on resistant PCOS. Madam is a MD, DGO, FICOG, FICM, Director and Fertility Expert at Safal Fertility Foundation. She's the Chief IVF Expert at SNE IVF Hospital, Bhopal. She's been awarded with the RCOG Distinguished Service Medal 2020, and there's a long list ahead. So I just welcome Madam on stage.
Thank you, dear Monica. Monica, oh my darling. So, thank you, Dr. Durusha, for giving me such a great opportunity. You know, this is my own place, my own land where I belong to, and I have all my nice, good friends supporting me. And it looks like going to be a grand success. Thank you so much. So when it comes to PCO, resistant PCO, you know, I have coined one very nice phrase for the ovaries. Mysterious two white pearls of reproduction, human reproduction. I find them very mysterious. Sometimes they're, you know, they're giving so many follicles, so many oocytes, and at the same time, there's, you know, they become resistant, they're angry, you know, jiddi. So how, you know, I'm going to talk about the hypo that Dr. Duru wants us to discuss in this conference. So I'm going to talk on the resistant PCO. So just introduction first, a chronic multifactorial reproductive and endocrine disorder. It affects about 9 to 18% of women, causes approximately 80% of anovulatory infertility cases. Now, insulin resistance is highly correlated with PCOS, and what is very, very great about this PCOS, it includes multiple clinical manifestations that may significantly impact patients' quality of life, including physical, social, and emotional well-being. It's a common condition, but the treatment modalities are very different. So here, I think Dr. Kiran Desai had also shown it, but in a different way. There are many factors that affect and then cause PCOS. Environmental toxins, genetic predisposition, gut dysbiosis. See, gut dysbiosis is very important. So nowadays we know that pre and probiotics have to be given in PCOS. Diet and lifestyle. This is the main heart of treating PCOS. All this will affect hormonal imbalance, hyperandrogenemia, and insulin resistance. All three are very important. In hormonal imbalance, we have increased LH-FSH ratio and decreased FSH secretion. In hyperandrogenism, we have increased testosterone and decreased SHBG. Insulin resistance, what happens is increased insulin levels and decreased glucose tolerance. And all this will act on the PCO, the ovaries, PCOS, and they give rise to these clinical features of hirsutism, acne, and reproductive features that are very important to us: oligoanovulation, irregular menstrual cycle, subfertility, and metabolic features which are risk of metabolic disorders. Now, signs and symptoms. One sign of insulin resistance is dark, velvety patches of the skin on the lower part of the neck, armpits, groin, or under the breast. We are having a very interesting session on this acanthosis nigricans in the session 5, wherein our PCO Society has published a good article, and I must congratulate Dr. Duru. I just read today morning that it has reached 100 reads, and she has I just read today morning. So a waist circumference of 32 inches to 40 inches based on gender and ethnicity. The triglycerides are elevated greater than or equal to 150 milligrams per dl or on medication to treat hypertriglyceridemia. Reduce HDL less than 40 milligrams in males or less than 50 milligrams in females. Elevated blood pressure greater than or equal to 130 or greater than equal to 85 millimeters diastolic, or they are on antihypertensive medication. I just wanted to include this neck circumference and insulin resistance. And before going to the neck circumference, I also want to tell you all that just by asking the patients and examining, clinical examination, I'm telling the science, you should ask them, do you have any skin tags? You know, you'll be surprised, many of them will tell, yes, we have. And even if they don't say, when you examine them, you will see generally they are on the neck, near the axilla, etc. They are clear indications that the patient has insulin resistance. Such a small examination and you will know, okay, this patient has insulin resistance. And neck circumference is the upcoming, for the diagnosis of PCOS, and they say it is better than the waist circumference. So neck circumference is a better correlate of insulin resistance markers than other standard anthropometric indices in patients presenting severe obesity. Generally, insulin resistance and obesity go hand in hand. So this neck circumference is helpful for early identification of insulin resistance in women with PCOS. This has come in the Fertility Sterility March 2021 original article, and it's a multicentric study. You can see so many authors are there. And a neck circumference of 34.3 centimeter is the optimal cutoff point for identifying insulin resistance in women with PCOS. However, there's one Japanese author who says 34.25 centimeters. Anyway, it's very easy to measure the neck circumference just below the Adam of apple, that point, and the mid cervical vertebra. Just take the circumference. Now, a little bit of pathology of insulin resistance. So, insulin resistance and compensatory hyperinsulinemia are considered major drivers of PCOS and involved in the development of androgenemia and reproductive dysfunction. Now, this hyperinsulinemia and insulin resistance is present in about 65 to 95% of women with PCOS, including the vast majority of overweight and obese, and more than half women of normal weight. This is a very important diagram which shows relationship between PCOS and insulin resistance. Here you can, I will only concentrate on the reproduction side. The genetic and epigenetic changes and the receptivity binding events, obesity, inflammation. Somebody already talked about inflammation. We have to remember that PCOS is also has a lot of inflammation, and environmental toxins and dietary factors. All this give rise to insulin resistance and hyperinsulinemia. And then what happens is that gives rise to androgen overload, and because of that, in the pituitary, the brain GnRH is increased. In the adrenals, the ACTH is increased, and in the ovary, the LH is increased. And that is the reason that there's a lot of changes in the hypothalamus pituitary axis and the hypothalamus pituitary ovarian axis, which gives rise to reproductive failure. I hope I'm clear. Now, this is one of the favorite slides which we keep when we are discussing about PCOS and infertility. This is the latest one, where first line of non-pharmacological management of infertility is lifestyle intervention or lifestyle modification. It's very, very important. Please spend a lot of time to explain your patients regarding these lifestyle interventions. Believe me, they will, if they do, and if you are a good counselor, you have to be one if you're a doctor or any other specialist, other multidisciplinary people are also there. You will win without going to the other treatment options. And then the first line of pharmacological management for infertility is letrozole, and it is the first therapy. Earlier we had clomiphene citrate, but we can also give clomiphene citrate. It's not our enemy, but then first line is letrozole, and we can combine clomiphene or letrozole with metformin and also gonadotropin. Second line of pharmacological treatment is the gonadotropins or surgical, that is the laparoscopic ovarian drilling or electrocoagulation. And then the third line of management is the assisted reproductive techniques, either IUI, IVF, etc. Now, lifestyle management, I think all of you know, but I would like to repeat this, that women with the WHO group 2 anovulatory with PCOS whose BMI of 30 or over must lose weight. I think even above 25 should be losing weight. And weight reduction alone may restore ovulation. It's very important. Just by losing weight, these women may have ovulation, improve their response to ovulation induction agents, have a positive impact on the pregnancy outcomes. 50% treatment of PCOS is simply weight control. Even if one loses 5 to 10 kg, the effect is tremendous. Now, in this, I would like to just tell two things. Supposing we want to advise something to our patients, first, we also should be a little bit not too overweight or obese. And we should, no, Monica, I'm not aiming at you. But I really think we should have. And the second most important thing that you need to tell your patients is discipline. If you have discipline in your life, you will get extra hours. Those extra hours you require for exercise and all. Binal is there, who is a good example of being very disciplined. And look at her. You know, that's how a doctor should be and a patient also should be. So we don't have to go into the pharma treatment at all. Sorry for the torrent people. And if 50% treatment of PCOS is simply weight control, even if one loses 5 to 10 kg, the effect is tremendous. Now there is a Mediterranean diet, which we all Indians, most of us, especially in Gujarat, you know, we are so many Jains and other people who don't eat meat, etc. This has a high intake of vegetables, fruits, not seafood, but legumes and nuts. Whole grains as staple foods, and the promotion of vegetable oils is very important. Low carbohydrate regime improves endocrine disorders and menstrual cycles in overweight patients with PCOS. Also, it's very good in fertility management. Now, the basis of ovulation induction in PCOS: reduction in insulin concentration, FSH stimulation, reduction of LH, and combination of all these. Now, what is the problem of ovulation induction in case of PCOS? There's no response. You know, I told stubborn jiddi. So the ovaries don't want to give any follicle or ovum. Then hyper response, that is multifollicular development, which are also not good. And then there again low number of good ovum is there. So we can consider this also in the hypo. I think Dr. Duru madam is going to talk that. Then high LH levels leading to low conception and high miscarriage rate. Sorry, F is there in the end. So there are, because of the high LH levels, there is high miscarriage rates. You have to remember that, and also low conception. This is one of my favorite slides. And I think if so many students asking me so many questions, but you know, there are some 6 classes or phenotypes. So here, I don't have too much time. So in the class, you can see class 1, 2, 3, 4, 5, 6. Then in the next group, normoandrogenic, normoestrogenic, non-obese and ovulation. So in that, wherever I have, in each class, you can see relatively obese, oligomenorrhea, and ovulation, hyperandrogenic, relatively obese, oligomenorrhea, increased testosterone, ovarian hypertrichosis. Why I'm telling you all that? These are all the patients who are having the resistance part. You know, they are not going to give you easily the follicles and oocytes. So the treatment is also wherever we have all this, we need to give them. Lifestyle management, everywhere you have to give. But wherever there's resistance, you have to give metformin, myoinositol, in some cases laparoscopic ovarian drilling and ovulation induction. In the class for hypertrichosis, you need to do the down regulation before OI, and you have to give gonadotropins, metformin and myoinositol, and some cases laparoscopic ovarian drilling. Now, for these ovaries which are resistant or intractable, I also call them intractable. So how do you do? The aim is to reduce the ovarian activity and bring the same at par with normoandrogenic and normoestrogenic state. Once they are normal, they will respond to letrozole or clomiphene or gonadotropins. Again, it all depends upon the age of the patient, the weight of the patient, etc. But the ovaries have to be made sensitized, and it is to be tailor-made. We can't have a formula which can be good for all patients. weight reduction for obese overweight. Now, we all know first line letrozole 5 milligram, it's 5 milligrams from day 3 to 7, clomiphene 100 milligram 3 to 7. I start from day 2. I don't know why, maybe my assistant has written day 3, sorry for that. Always monitor the first cycle by TVS. Then the second therapy, metformin in combination with CC or letrozole, laparoscopic ovarian drilling has a role, I'll come to it. And then additional therapy, first you have to, for PCOS patients, please try lifestyle, then, reduce your weight, then make the resistant ovaries into, sensitize them, and then give the basic treatment. Don't jump into IUI and IVF just because we are going to get some more money. Just these additional therapies will come at the last, IUI, IVF, and last, the bariatric surgery. There are few patients who really can't lose weight and they're so overweight, the BMI 40, 43, I've seen them. And in such cases, if you fail to lose their weight, then bariatric surgery is indicated. Once again, you have to do a baseline TVS on day 2 or day 3 to rule out any ovarian cyst or any other pathology. And letrozole, see, again and again it's been repeated, first line, and then clomiphene. And then you have to, for all these patients, when you give ovulation induction drugs, please do proper monitoring. It's very simple. I think everybody has transvaginal sonography like a stethoscope nowadays, all the gynecologists have. And so monitor by TVS to confirm adequate follicular response and endometrial growth. Okay, now these are recommendations from the 2023 International Evidence-Based Guidelines for the Assessment and Management of Polycystic Syndrome. There are many countries who have participated, and I'm very proud to say that our PCOS Society of India has also participated in this recommendation. Dr. Duru Shah is the main person for that. And here you see we have given evidence-based research. We have given points, evidence-based research points or practice points, where there is no evidence but still you can give. So letrozole has a very high evidence of 4 points. And others I'm not going to read because it's all there, I think the torrent, you all will get this guidelines book, PCOS, it's a very big book. And if you want, just let me know and we can get, all of you can get this. It's very useful. Now, second line of therapy, metformin, recommended daily dose is 850 milligram twice a day, but I generally give 500 milligrams 3 times a day. Initially, I start with just half a tablet of 250 milligrams, and I tell them to take only in the morning, evening for 3 days, and gradually increase the dose so that the patients will get acclimatized to metformin, because metformin gives a lot of gastrointestinal disturbances, which then the patients will stop. We don't want them to stop. We want them to continuously take it for a long, long time. So we have to be very clever in giving the patients these medications. Then we have laparoscopic ovarian drilling. In selected cases, women with thin, lean PCOS, the indication, and they're resistant to clomiphene citrate. Many patients are resistant. So in these patients, laparoscopic ovarian drilling is indicated. Gonadotropins, generally they say recombinant FSH or even ordinary FSH should be used in CC resistant cases or with CC failure also. We have a low dose step-up protocol starting with 37.5. But I, however, see, whatever I practice, I'm telling you, only in affluent patients I use the recombinant or FSH, highly purified FSH. Otherwise, most of our patients in our country, they're not too rich, and then I use the HMG. Nothing happens, it's good. And actually, I have saved one of my patients from that. She had that FSH polymorphism, and because I gave HMG, we didn't have problems. So now this starting low dose setup, it's also in PCO. It's a chronic low dose protocol. So what is chronic dose? You have to give a dose for a long time. That's chronic. And then you have to have the patients, there will be a proper dominant follicle. If every 7 days you check, if there's no dominant follicle, you increase slowly the dosage. That way you'll get a monofollicular ovulation, and you'll not have the problem of ovarian hyperstimulation syndrome, etc. So it is common practice to perform IUI when gonadotropins are used. Yeah, that should be there. I remember in my earlier days when I tried many times clomiphene and all, and ultimately that time there were very few companies of gonadotropins, and I gave that. And she conceived. So she was so angry with me. She said, "Why did you not give this gonadotropins earlier? I could have conceived 6 months or 8 months back." So you have to judge the patient's this thing and then give. So these are some common pharmacological approaches for reducing insulin resistance. Most, it has got the category, generic name, reference, mechanisms of improving, how it improves, common side effects, contraindications. But I can tell you the mostly what we use is biguanide, that is metformin. But today Dr. Vivek Arya so nicely explained, and maybe we can use I heard also that some of them are using the DPP4 inhibitors as well, semaglutide and sitagliptin. So, but as far as we gynecologists are concerned, I think we are using more of metformin, and there are other medications also which you all can, if you want, I can share the PPT. Now, metformin is one of our favorite, medications, molecules. It is not indicated as a primary ovulation induction drug in PCOS, but with combination with clomiphene or letrozole, or just metformin for pregnancy rates, you can go ahead and give. Metformin reduces the incidence of OHSS in PCOS. This is according to the Cochrane database. Now, there are about 1,660 publications and 13 RCTs where effects of different insulin sensitizers in the management of polycystic ovary syndrome is seen in this. It's a very recent 2023, and they have shown that metformin was superior in lowering weight, and testosterone versus and metformin actually it reduces the body weight and also the testosterone levels. Sorry about that. So this is a very good study. Now, role of insulin sensitizers in the treatment of PCOS. It's very interesting to know that the insulin sensitizers really act on the insulin, on the adrenal cortex, liver, and androgen, on the ovary, which does act on the androgenic activity and increases this. And so clinical manifestations are infertility, menstrual disturbances, hirsutism, and acne, and also long-term consequences are the cardiovascular diseases. Once again, the recommendations here you can see metformin, according to our recommendations from 2023 international evidence, it has evidence-based research point, and it should be considered with adults with PCOS. So we are all considering it also. Now coming to myoinositol, I think all the some of the conferences and many places have seen that some doctors are against myoinositol, like Jani Dushman, but I don't know why people do use myoinositol, and now we have some references also. I'll show you. Actually, the myoinositol is given in 4-gram dose for patients with depression, etc., and psychiatric treatment. We are just giving 2 grams per day. They say it improves. There are very few articles for supporting this. And now this is the latest. It is printed in 2024 in Curious, and 90 women included in the study received 1 gram BD for 6 months, and around 68% of patients restored menstrual cycle regularity. So we need to still do a study on myoinositol. Yeah, so now here I put the recommendation from our very own international evidence. Here it has evidence-based research point, it has got 1, and and metformin also has got 1. Now dexamethasone, it directly suppresses the estradiol effect on pituitary gland and improves follicular development. Indirectly, it increases the growth hormone. Now doses, low dose it's very important to understand we have two types of doses. One is low dose 0.5 milligram per day and high dose 2 milligram per day during CC from day 5 to day 9. This dexamethasone is generally used for clomiphene citrate resistant cases. So benefits women, DHES where it is more than 2 nanogram per ml, improves response to CC in PCOS. I already told you CC resistant PCOS. Now coming to the laparoscopic ovarian drilling. It was introduced in 1984, evolved to become a safe and effective surgical treatment for anovulatory patients, infertile women with polycystic syndrome, unresponsive to clomiphene citrate, as effective as gonadotropins in terms of pregnancy and live birth rates, but without the risks of ovarian hyperstimulation syndrome and multiple pregnancies. And the best part of laparoscopic ovarian drilling is it's a one-time treatment modality. You don't like this letrozole and gonadotropins every month you have to give, but this is a one time, and then the patient starts, if you have done properly, the patient starts ovulating on herself. So what are the advances in ovarian drilling? It's done with a monopolar hook electrode, or it can be also done by harmonic scalpel. Office microlaparoscopic ovarian drilling is now proposed. Transvaginal hydrolaparoscopy, that is fertiloscopy, is also coming into vogue. Transvaginal sonography guided ovarian interstitial laser treatment are also developed. I remember Dr. Rajan from Kerala, he used to do just puncturing of the ovary transvaginally to decrease the ovarian stroma. Now, pregnancy rates after laparoscopic ovarian drilling, they have seen a good increase, like earlier it was 39, then it has gone to 77. Pregnancy rate also, it was 33 and it has gone up to 47. So, laparoscopic ovarian drilling done for the right patients, right indications from the right laparoscopic endoscopic surgeons will give the right results. Now, re-drilling, should it be done? Ovulation and pregnancy are 60% and 53% better outcomes in laparoscopic ovarian drilling, sensitive than resistant cases. Concerns of additions precluding the feasibility of a RCT is there. Until then, repeated application of LOD should not be encouraged. So, the second look laparoscopy and drilling, that should not be the norm. Just do the drilling once, and I think that should suffice. Once again, the evidence-based research points are two, which means it is good. Now, IVF. This is the last part of my talk. Before ovarian stimulation, you have to review the lifestyle. Metformin you have to give to decrease the ovarian hyperstimulation syndrome. During ovarian stimulation, low dose stimulation has to be preferred, preferably FSH, and then you can also use HMG, as I told you. Please use antagonist protocol. Because these days the norm is ovarian hyperstimulation syndrome free clinic. That is the norm. Nobody should have any case of ovarian hyperstimulation syndrome. So this antagonist cycle should be more preferred. So in antagonist we give a trigger of GnRH agonist, which does not give risk of OHSS. If you give a HCG, there will be a risk. Even when you are doing IUI, etc., and then there are too many follicles and you can't do IVF, you have to advise the patients not to not to have intercourse, and otherwise if they conceive naturally, she's going to have a chance of ovarian hyperstimulation syndrome. So whenever we are catering for these patients of PCOS for infertility, we may not give them a baby, but at least don't give them life-threatening complications. So, managing fertility in PCOS with insulin resistance, dear friends, is a multifaceted approach combining emotional support, early intervention, personalized care, lifestyle changes, pharmacological therapies, and systemic approach along with the above strategies will significantly improve reproductive outcomes. Thank you so much for a very patient hearing. Thank you, Chairperson Dr. Mahesh. I call Dr. Mahesh the savior. Dr. Duru, Dr. Mahesh Gupta, he is so good in his, the PPH when they start bleeding and all that. He goes to the doctor's hospitals ties the uterus and he saves the patient. So I have named him as the savior. Yeah. Yeah, and
Thank you.
Dr. Nisarg is, upcoming, not upcoming, he has so many chain of IVF centers, and I am very, very happy to be joining with Sneha IVF, and we both together are going to have a great, giving more and more babies to our patients. Yeah, so thank you all the three chairpersons, and yeah.
So thank you, Madam Kanthi Ben. If there is any questions from audience, because as a chairperson, I am not good in speaking or on this topic. Yes, Lata. Yes, Dr.
But
Deep.
Mahesh, we don't have any patient who's bleeding with,
No, I always wish all the best for these IVF people, because if they work more, then my work will increase. Right, Dipesh?
Well, my question to Dr. Kanthi Bansal is, you are one of the pioneer IVF specialists in Gujarat, and I always appreciate you. My question is that what is your cutoff level of LH, and do you do AMH before laparoscopy drilling and after laparoscopic drilling in the era of DOR? I mean, a poor reserve of ovary, or you have some ultrasound norms also before doing laparoscopic drilling?
Yeah, thank you so much, Pavan, but you're asking a very wrong person, because I'm not a, really endoscopic surgeon, but I can still answer your questions. I will definitely do a ultrasound and confirm, actually the volume of the stroma. That is very important when we think about ovarian drilling. And LH levels also have to be high. I don't know exactly, but I think more than 10 at least, because in IVF we want less than 5 to get results. So what was the third one? AMH. It's very tricky. AMH, we don't have any cutoff because most of this PCOS patients are having very high AMH, and I have seen the right person to answer all this is come. So the when we do ovarian drilling, the Pavan, I am answering. You have to listen to me. Yes. Manish. Okay. So when we are doing drilling, however well the laparoscopic surgeon does, there is a decrease in the AMH levels, but we have to be very careful that we are not really making it so low that the patients can't have pregnancies later on. It is a very tricky situation, and there is nowadays that 4 points and 4 depth and all that. I feel it should be on the volume of the ovary. It cannot be, it is not a tailor-made sort of. Yeah, this is my answer to you.
Yeah, Lata, you are asking something? Yeah.
Metformin? All tricky questions you people have collected, I think, for me. Anyway, metformin I give till delivery. Yeah.
The recommendation for just a moment, madam. The recommendation for metformin is that any of the PCOD patient who has been taking metformin, you should continue for the first trimester at least. You should not stop as soon as patient is pregnant. Don't stop metformin. Continue at least for first trimester, and if you continuously give it till full term, there's no issues with that. It is absolutely safe.
Lata?
Yes.
Yeah, Lata. So.
Yeah, Joel.
Jewel.
Hello, ma'am. Just to answer, clarify on the topic of fertility, when we do ovarian drilling, the purpose is not to reduce the AMH. So, अगर AMH 6 था तो 6 रहना चाहिए. The purpose is to reduce the intra-ovarian androgen levels. So, AMH is that. Hence, it is important to do AMH so that we know after drilling we have not reduced the ovarian reserve. We just want to decrease the stroma. not the follicles inside.
Yes, well, but just tell me the truth. How many patients they come to us, ड्रिलिंग करा के हम दोनों तो नहीं कर रहे ना ड्रिलिंग, तो हमारे पास आते तो कितना कम होता है ना.
We do, many people do grilling, not drilling. So we want her के period regular हो जाए, भले जो भी हो.
Yeah.
But that is not the purpose of ovarian drilling.
Yeah, Lata, what you were asking? हाँ, myoinositol.
Only
Okay.
myoinositol
Okay.
without
I'll
metformin.
tell you the answer. I want to know, Nisarg and everybody here, raise your hands. How many of you use myoinositol? I think Nisarg, you're not using.
Now onwards he will start using. You are asking of 2 gram or 4 gram.
Actually, I'll tell you, when I started my practice, infertility practice, I used to get all sorts of patients. I used to get the girls who have not got the menstruation, primary amenorrhea. And you won't believe that, I used to give metformin or they have gone to many gynecologists in Ahmedabad, but ultimately when they came to me, I diagnosed PCO tha, and I gave them metformin. That is one thing. But later on, I started giving metformin for resistant cases and all that, but I'll be truthful. Then there was a combination of metformin and myoinositol, and I started giving that to my patients. Believe me, I had fantastic results. I have a huge PCOS patients coming to me from all over. So, but now there is a little bit of discrepancy whether we should give or not. But it has not caused any harm to my patients, so I used to give, and for some patients I just give some metformin, and for some I give combination.
Yeah, this one, just I'm concluding this session. The one contradiction I have observed in IVF, particularly IVF lecture and from IVF speaker, when they speak from the dais, they always talk very rationally that you should prescribe this thing, you should not prescribe this, you should not prescribe. But if we see their prescription, they use all orifices of the woman, starting from the mouth to the vagina to the rectum and to the skin. And their prescription is full of all orifices,
Mahesh.
all orifices they are using. But when they come on the dais, no, irrational progesterone should not be given. Irrational SCG should not be given. And one of my IVF friends used to tell me that so much vaginal progesterone was given to one patient that it becomes a ball after a few months. So anyway, it was on the lighter side.
Yeah.
But one thing just you have mentioned the 2 shiny small balls in the woman abdomen, that is ovary. So one thing is sure that all women born with the full set of ova when they born, unlike men. When men born, they are not born with the sperms. It starts developing after 12 years, but all women, they born with the full set of ova. So this is the difference between men and woman. So woman is more complete when they born, rather when the male when they born,
देखो,
they are incomplete when they born.
महेश, पहले तो तुमने है ना इतना वो बोला सब IVF people are doing this and that, and then to compensate you're telling we are having some pearls and all. What is this? Anyway, thank you so much. It was so humorous and very nice. Thank you.
Thank you, madam.